I'm Elliott Antman, President of the American Heart Association. Our third late-breaking clinical trial session deals with structural heart disease. There are two very interesting studies looking at losartan.
We have a trial comparing atenolol versus losartan in patients with Marfan syndrome. An important question that comes up all the time is whether patients with Marfan syndrome and dilated aorta should be receiving beta blockers versus angiotensin receptor blockers. This is a trial comparing those two strategies, and so I think these results will be very important for us in terms of the potential benefit of these drugs, either one, in terms of the progression of aortic disease in patients with Marfan syndrome. Losartan is also being tested in a second trial called the Inherent trial of patients with hypertrophic cardiomyopathy, determining whether angiotensin receptor blockade is beneficial in patients with hypertrophic cardiomyopathy. We have no evidence yet that these drugs could be beneficial, and this could be practice changing if indeed ARBs are successful in improving symptoms and outcome in patients with HCM.
The interesting aspect of the Inherit trial, the one with hypertrophic cardiomyopathy, is that some of the individuals who will be enrolled in that study actually have a positive genotype but don't yet have the phenotype of hypertrophic cardiomyopathy. And the question, of course, is whether losartan can prevent the development of the hypertrophic state.
We really need to understand what's the evidence say about what we should do when that mitral valve is not functioning properly in the setting of coronary disease.
And finally, the last discussion in that clinical trial session is coming from the NHLBI Cardiothoracic Surgery Network of patients undergoing coronary bypass surgery with moderate mitral regurgitation to determine whether one should do mitral valve surgery at the time of CABG in patients who are already in the OR, already undergoing CABG, have moderate MR, not severe MR, and these patients have been randomized to undergo mitral valve surgery plus CABG versus CABG alone. So a question which comes up all the time in our patients with coronary disease and associated less than severe mitral regurgitation.
Several years ago, the recommendations for prophylaxis against infective endocarditis were changed, and we restricted the number of individuals or the profile of patients who would be getting prophylactic antibiotics. The question we all had when that modification was made was, will we see an increase in the incidence of endocarditis if we reduce the number of individuals for whom we give prophylactic antibiotic therapy? There'll be an interesting report in this session coming from the United Kingdom examining the incidence of infective endocarditis after this transition was made to a much more restricted use of antibiotic therapy.
I think the combination of these four trials, although somewhat heterogeneous, will lead to important implications regarding how we manage our patients with structural forms of cardiovascular disease.